Assalamu alaikum wa rahmatullah. My name is Abdurrahman Nimeri, and it is my pleasure and great privilege to be part of the Libyan Society for Metabolic and Bariatric Surgery Conference. I would like to thank Dr. Fathi Zawawi and Dr. Khalid Al-Jawzi, the presidents of the conference and the society, for the kind invitation, and hope to join you next year in person. I was asked to speak about the general concepts in preventing complications in bariatric surgery. And without further ado, I'll get started. This is my disclosure slide. It has no relevance to this presentation. You can see that 60% of what I do is Roux-en-Y gastric bypass, and about a third is sleeve gastrectomy, and 10% is duodenal switch and SADIs, and approximately 20 to 30% of what I do is revisional surgery. So I think the three main concepts that the presentation will revolve around are how to prevent complications, and if they happen, how to detect them early, and then some tips and tricks to management. I'll first describe how the safety of metabolic and bariatric surgery improved from a mortality of 4% of gastric bypass in the 90s and early 2000 to a mortality similar to cholecystectomy today. We'll also talk about something called the failure to rescue concept and give you my tips on how to manage leaks, upper GI leaks, whether from the stomach or the esophagus. Then we'll talk a little bit about risk assessment, procedure selection, and how to prevent blood clots in bariatric surgery, and conclude by discussing abdominal pain after Roux-en-Y gastric bypass, one anastomosis gastric bypass, and duodenal switch and SADI, and share with you some videos. You can see the progress of bariatric surgery from the 1950s with the GI bypass to today have gone through several iterations of procedures, and some surgeons have had impact twice, like the late Ed Mason and like Michel Gagne. But GI bypass had a 10% mortality. Open Roux-en-Y gastric bypass had a 4% mortality. Today, the mortality of laparoscopic Roux-en-Y gastric bypass is similar to cholecystectomy, 0.1% mortality in 1 month. And this safety happened because of several reasons. And because patients, on the most part, value safety, sleeve gastrectomy is a procedure that's been shown to be effective, but extremely safe. And maybe that's why it's the most common procedure today. But the things that has led to improvement in complications, as you can see in the yellow line, and improvement in mortality over time, and a significant drop in the morbidity of surgery, has to do with adoption of laparoscopy. So you can see in the blue line, open surgery dropping, in the red, laparoscopy going up. Fellowship training. So these are the fellows that have had the privilege of spending at least a year, some fellows too, in fellowship training, either in Fresno, at Sheikh Khalifa Medical City, in Charlotte, or here in Boston. So fellowship training is a very important component to improvement in safety. Accreditation is another one. So in the US, to perform surgery, your hospital has to be an accredited center with the metabolic and bariatric surgery accreditation and quality improvement program, which is a joint program between the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery. And there's been studies to show that if you look at minor complications, there's no difference between accredited and non-accredited centers. But if you look at major complications, there's a big difference. So what is the failure to rescue concept? This is a very elegant study that was done by Justin Dimick, who is the chair of surgery now at the University of Michigan. And in this study, they looked at mortality in 300 hospitals that were participating in the ACS NSQIP, American College of Surgeons Quality Improvement Program. And in number one bars, there are hospitals with the lowest mortality, 3.5%. Number 5, hospitals with the highest mortality. And their hypothesis was to look at complication rate. And they expected to see a similar complication ladder. But what they found was that the entire complication rate, major complication rate, is no different between hospitals. Yet, if you show up in hospital number 1, you survive. If you show up in hospital number 5, you don't. So it's not the complication that leads to mortality, but what happens after the complication, what you do after the complication. And this is so if this is the complication about to happen, what you do after the complication happens could save your patient. And this study from MBS Safety shows that leaks happen more often after gastric bypass, and that's why we select high-risk patients to undergo sleeve gastrectomy. So procedure selection is exceedingly important. High-risk patients should be specifically selected to have a sleeve gastrectomy. It's important. So what are the principles for management for upper GI leaks? It's important to know that you could treat patients conservatively, you can have endoscopic means, or you could take them to surgery. So the initial management, revolves around resuscitation, starting IV antibiotics, trying to get some basic radiographic studies, whether CT or upper GI, and having a plan for enteral feeding. If you decided to take someone to surgery, you want to make sure you have the most experienced anesthesiologist and assistant. You want to make sure you have a capability of doing intraoperative endoscopy to rule out distal obstruction. Prepare your drains and prepare what tubes you want to use. This is not a patient you want to extubate after surgery, and this is not a patient that you want to send to the regular ward. This patient should go to the ICU, maybe kept intubated for that night, and then have a plan for VTE prophylaxis. And most importantly, do not perform any major resection or reconstruction. Treat it similar to a damage control laparotomy that happens in trauma surgery. Then with endoscopy, evaluate and make sure there's no distal obstruction, a stricture in a sleeve or a stricture in a gastrojejunectomy in bypass. And then after surgery, have a frank discussion with patients. I tell patients and their families that a sleeve leak takes 3 months to heal, a bypass leak takes at least a month to heal. So this is important from the very beginning. And when you say that, you gain credibility. When it materializes, if you don't, they get frustrated when the time takes long. Most drains you place you should remove by 3 weeks, because then they become the foreign body that prevents the leak from healing. If you can, try enteral feeding rather than parenteral feeding. And if the patient had either SADI or one anastomosis gastric bypass, you need to have a plan to divert biliary peritonitis. So if a patient shows up with tachycardia, it's easy. Most surgeons get a CAT scan, and if it's positive, they take him to surgery. If it's negative and the patient improves, there's no issue. The issue becomes when the patient has negative radiographic studies and they still have symptoms. And those patients require the ultimate diagnostic test. If there's one thing I want you to remember from the presentation today, is that in bariatric surgery, laparoscopy is not surgery. It's a diagnostic test we do in the OR to make sure that the patient does not have a stricture. And when we do Roux-en-Y gastric bypass, we do this primarily to make sure that the patient does not have a leak. So we've published an algorithm to take care of sleeve leaks, and the algorithm is based on doing a CAT scan after the upper GI, doing an endoscopy to rule out the stricture, and then making sure you have enteral rather than parenteral feedings. We don't use stents and try to expedite ambulatory care by using enteral feeding. So leaks could be as significant as this picture. This is a type 2 leak where someone has significant amount of contamination. Typically what you need when you take someone to surgery is suction and a grasper. That's all what you need. And using those, you could actually take care of most of leaks, and then you can do an intraoperative endoscopy and spend as much time taking care of this fibrinous exudate and removing it. So rarely anything more than suction and graspers. Now, on the other hand, some leaks are called type 1 leaks, where there is not much contamination like this patient. So This is a very elegant poster that ASMBS publishes that you can get yourself. We put it in our emergency room. So when someone comes back, the ER physician knows what types of procedures we do, how do they present, and what things to look for. How do you make sure the patient doesn't have thiamine deficiency? How does an X-ray of someone with a band look like? So in terms of risk assessment, it's important to know that sometimes these complications can lead to lawsuits, especially in the US. And one of the most common reasons for being sued in the US in this review was having a leak, technical error, bleeding, or vascular injury. And especially in gastric bypass, this is a review of 100 medical legal claims, and prevention of leaks and their timely management was probably the single most important strategy. So a leak and collection were the reason for someone being sued 86% of the time. And what's important is that 15% of the time, the surgeon who took care of the leak was not the surgeon who performed the surgery. So you want to make sure the person who covers you has as much skill and expertise as you do. And a survey of ASMBS members to look specifically at being sued found that the probability of being sued correlates with the number of procedures you've done and the numbers of years you've been in practice. One of our program directors when I was a resident used to say, if you go to the mountain often, you'll meet the tiger. So it's important to know that leaks will happen. And surgeons don't get in trouble because they had a leak or a complication. It's because there was a delay in diagnosis, there was not adequate surgical coverage, or the possibility of leak or complication was not discussed with the patient. Expectations are not there. Then another important thing is, obviously you can't plan on not having complications, but you can plan on how to manage them, develop a good relationship with the patient, and only do procedures that are endorsed or established in your region. So in the US, if I do bipartition procedure or I do SASI, I'll probably get in trouble because the patient gets a complication. Then this is not a procedure that's endorsed with or by ASMBS. Shifting gears to venous thromboembolism, today the #1 cause of death after bariatric surgery is having a PE, a pulmonary embolism. And if someone has a PE, this is at 30 days, the strongest independent predictor of dying at 1 year after bariatric surgery. And the mortality is 25 times higher if someone had VTE after discharge. So having a strategy is important. Why? Because in this study from Ali Aminian's group, looking at more than 90,000 patients who had surgery in the ACS-NIS group data set, 80% of leaks happen after discharge, and they continue to happen up to 30 days. So what we do is we published our first study when I was in Abu Dhabi looking at a risk assessment tool, and we used the Caprini risk assessment tool in not only bariatric surgery, but the entire department of surgery, and have shown that that's effective. And then recently, when I was in Charlotte and now here in Boston, we've published actually a method by which you could use the Caprini risk assessment tool. And we found that in our publication when I was in Charlotte, if a patient misses a dose or two, the risk of a venous thromboembolism is higher. And very soon we're going to have, we've just published this calculator comparing the different calculators using the NUSCOPE data. And this calculator, the St. Luke Brigham calculator, is going to come soon, and you'll be able to plug in your patient information. It'll be in both, like platforms, Apple and Android, and then you could just plug in your patient information, and it will tell you if your patient's is a high risk for VTE. Anybody with a 0.4% risk or higher is high risk, and then you can decide that those patients before discharge can go home on prophylaxis. Finally, if you look at abdominal pain after gastric bypass, we talked about acute abdominal pain, and at the end, if there is nothing revealing patient still has pain, you do laparoscopy. But it's important that if someone has chronic abdominal pain, maybe you get an ultrasound first, have gallstones, they get laparoscopy. Maybe you get an endoscopy if it's continuous. But what's important is if everything is negative, you need to conclude by a laparoscopy. And you need to know that internal hernias happen the most common if you do a retrocolic bypass less common if you do anticolic bypass, but they also happen in someone who has a loop bypass, like SADI or one anastomosis gastric bypass. Matter of fact, Dr. Peterson described Peterson hernia, Walter Peterson, in 1900 in patients who had a Billroth 2 operation. Very similar anatomy to one anastomosis gastric bypass and SADI. And there's been reports of internal hernias after both one anastomosis gastric bypass and SADI. And this Swedish study put the issue of closure of internal hernia spaces to rest. This is a very famous study that was published in 2016. 12 centers in Sweden, period of 1 year, and they have 99% follow-up rate. And what they found was initially in the closure group, there are more obstructions. But over time, there are less obstructions and less internal hernias, probably at the beginning because of learning curve. But what's important is the internal hernia rate is very clearly lower in the closure group. How do we close our defects? This is a very short video that shows how do we close the defects. We use non-absorbable suture, continuous, and we start from one side and try to avoid closing the mesentery of the rulum. So at the bottom here is the mesentery of the rulum, and this is the space we're trying to close. So this bite is going to go into the mesentery of the rulum, and then I'm going to realize that, and then go back and go up. And then you take the suture, go all the way up to this side, and that's how you manage closure. And the same way you would close Peterson space. Why is that important? It's important because it's been shown that this maneuver, closing the defects at the time of bypass, is what leads to a lower rate of internal hernia. So once you tie this purse string suture, you use the same suture to create an anti-obstruction stitch. And you can see once you tie this, the defect is. So if someone comes like this video with an internal hernia, you cannot untangle the bow tie of the internal hernia like this. This is not the best strategy. What you need to do is you need to tuck the patient's left arm. You want to start by standing, you and the person holding the camera, on the left side of the patient. And then you basically start from the ileocecal valve. So you completely ignore the presence or absence of hernia, because you will not be able to decipher which part is the part that you need to take care of. So what you need to do is you need to identify the terminal ileum. So this here is the terminal ileum. So you can see terminal ileum, cecum, the entire bowel is incarcerated. And once you pull this terminal ileum towards the ileocecal valve like that, you will reduce any hernia the patient has. So this is the single most important principle in reducing internal hernias. Tucking the patient's left arm, placing a camera port too low than you usually do, and then reducing bowel starting from the ileocecal valve. And this will reduce any incarcerated hernia. So that's the first important principle. You can see now the hernia. The second is, if someone has pain and they present, they need to be taken to surgery right away. This is a patient that presented with abdominal pain, and you can see when we took the patient to surgery at midnight, there's a clear color difference between the distal bowel, pink, and the proximal bowel that's incarcerated, blue. But within 1 minute, once we reduced all the bowel regained color. So this is a true surgical emergency. You know, acute abdominal pain, long time after gastric bypass, or one anastomosis gastric bypass, or duodenal switch or SADI, requires that you take the patient to surgery for exploration. And as I said, this is not surgery. This is a diagnostic laparoscopy done. It's a diagnostic test to make sure, so it could be negative. And you see, once we reduce all the bowel will regain color, and this patient did not need bowel resection. And then it's important to take someone back with abdominal pain to surgery to explore. They have, this is the last video I'm going to show, something like this. So we start the exploration by looking at the gallbladder. Then we go examine the pouch, make sure there's no gastric fistula, make sure there's no evidence of inflammation. This patient had retrocolic bypass, as you will see. Then we follow the rule back, and because it's a retrocolic bypass, the Peterson space hernia will be below the colon. If it's an anticolic bypass, it will look different than this. So you look for it. And then the most important thing is at this point to do an endoscopy. So this patient, there's no abnormalities, but the patient has continuous postprandial pain. So we ran the bowel to the JJ, and there's no abnormalities. But then when we did an intraoperative endoscopy, we could see a suture on the inside. And the closure that the surgeon used to do for this JJ, he would close the JJ, pass the suture underneath the rulum, and then use the same suture to close Peterson space. And in this patient, the patient had an erosion of that continuous suture. And you can see here on the endoscopy, we can see the suture, and then that led us to identifying that that patient had a suture. So we found the suture, removed it, and the patient's pain went away. So it's important to be very systematic. You can see that white structure is what we saw on the endoscopy. You can see once we cut that, it's actually a circle, complete circle. That's why it was causing pain. Once we cut it, divided it, and removed it, the patient improved. So the take-home messages are to manage complications, you need to prevent many of them. You need to detect most complications early and have a strategy to manage them. Today, metabolic and bariatric surgery is as safe as cholecystectomy. Leaks today are more common after duodenal switch than Roux-en-Y gastric bypass, and they're the least common after sleeve gastrectomy. So high-risk patients probably benefit from being selected for sleeve gastrectomy. Severe leaks need wide drainage, an experienced team in the OR, enteral nutrition, and a plan to manage distal obstruction, and a multidisciplinary team strategy to manage the patients. All the times if you manage internal hernias, make sure your ports are lower than usual, start from the ileocecal valve, tug the left arm, and have a systematic approach. When you look at risk assessment, we assess patients, and if they're high risk, we do a sleeve. We assess the patient, and if they're high risk for VTE, we give them extended VTE. So again, I want to thank you for the invitation to present today, and look forward to see you next time in person. Thank you very much.